Hey gang, section 4. I hope everyone's doing well. Here we are for the weekend wrap up for week 2. Another great week of information, some good dialogue. I hope you all were able to get some helpful information that you can take back to the clinic right away and kind of put in perspective what it is to treat subacromial impingement syndrome. You know, what even that name really means and how we deal with it. It's a bit of a quandary, if you ask me. We need to perhaps move on from that diagnosis to do a better job, and we'll kind of get into that as we talk about this. So, some of the highlights. I think the Park and Michener articles are really great articles to help you think about what really special tests are, and not only for the special test of the shoulder, but kind of collectively, whether it's a knee special test or an ankle special test. These special tests are a bit of a challenge. In the Park article, I thought that there was a really large N, and I didn't see too many people talk about the N, the number of people in the sample, and that's really important to have a bigger N. I think the Michener article had perhaps a better study done, but didn't have as many people in it. Both can guide us in our clinical decision making. We can use both of those studies to help kind of guide where we want to be. The Michener's ruling out, I really like that because of the strong negative likelihood ratio of 3.35. Anything, it's a moderately strong, and reminding you that a resisted external rotation, a negative NIRS, and a painful arc. Whereas Park ruling in for impingement, the positive likelihood ratio of Hawkins-Kennedy painful arc, pain with infraspinatus muscle testing. Those would be what I would use to rule in. And then the rotator cuff. The drop arm in my mind is the biggie. The infraspinatus muscle testing, right? Weakness with resistance or nothing there. And then the painful arc as well. Painful arc being the kind of the catch-all in this case. So in my mind, that's how I would view this, what my take-homes would be for this, the Park and the Michener, for ruling in, ruling out, and then the rotator cuff. But, with the cuff, again, and all of these are so challenging because as we're going to learn when we start to study rotator cuff, what does that really tell you? Do they need to go right after surgery? Probably not. That's in the subacromial people, the decompressions. You don't even get me started on those. I really liked Eric Robertson's presentation. It was good stuff. And a lot of people commented on the primary versus secondary impingement being kind of a good reminder of what we're really trying to accomplish. Primary related to posterior capsule tightness, a tendinopathy. Secondary related to instability or poor motor control. And somebody asked me, and now I'm drawing a blank. I'm drawing a blank on who it was. But, do you see from an age standpoint, and I would argue that primary versus secondary, and I would argue, any age can have either one of these types of problems because I think of the deconditioned being part of the secondary and the tendinopathy being more of a overuse, postural, perhaps, but more of an overuse, repetitive use kind of thing. The Bang and the Minkin article, the strength of manual therapy and therapeutic exercise. So the big question is, are you using manual therapy with your patients who have subacromial impingement? Both the Minkin article, the Bang article, I posted the MUH article in Dropbox for my groups, all talking about how manipulation is a very effective tool, especially thoracic manipulation. Now, there is some conflicting information on cervical. I would argue cervical can be very effective, but Cook's article that I posted in Dropbox, they didn't find that to be the case. We can talk about, maybe if use thrust versus non-thrust, perhaps, whereas we know that thoracic spine manips are much more appropriate. But bottom line is, if you're just performing manual therapy on the shoulder, you're missing the boat, okay? We need to take that regional interdependence approach. It's the key in every patient we see. The Bang article and the exercise program, scap strengthening, rotator cuff strengthening. Are you doing this? Strengthen. I always tell my patients we're getting you stronger to make you more durable. We do manual therapy as a bridge to decrease pain so that you can exercise. It's always about exercise, getting you stronger, making you more tolerant. Here's my 2 cents. Cervical spine and thoracic spine is highly undertreated for shoulder pain patients. Please, if you learn nothing from this course, please treat the cervical and thoracic spine. That's going to be a big deal. Okay, now lower cervical spine APs, anterior to posterior mobilizations and firstward mobilizations on ipsilateral side is a big deal that I found. So classically, and I've said this in a couple, and I say this down here at the bottom in my last bullet point, When NIRS is negative, I go to the cervical spine. And I find that anterior shoulder pain, bicep stuff, unless there's some kind of thrower or doing some kind of repetitive use thing, it's completely overblown and it's just not there. And a lot of time anterior shoulder pain is about what's coming either from median or radial nerve, or stiffness within the first rib and stiffness within the lower cervical spine. So I will do AP glides. What are AP glides? I will put my thumb on the anterior body of the transverse process of C6, C7, C5, and I will glide, and I will usually do a rotation into that glide, right? So if it's a right-sided dysfunction, I'll mobilize on the right anterior posterior border of the transverse process and rotate passively into right rotation. I learned these tricks in my fellowship, and they work, and you see immediate change with these people. And oftentimes they'll get referred pain when I'm pushing on that. And certainly I could be mobilizing the neurovascular structures as they come out of the neck, and they'll get referred, or they'll get pain that kind of goes down into their shoulder. Like, yeah, that's my pain. Sometimes they'll say that. I often look at pure shoulder abduction as being another indicator. So oftentimes first rib will be stiff, and in shoulder abduction they'll get up to like 150 degrees. And I usually keep the shoulder, when I do that abduction passively in sitting, I'll have palm down so I get a really true idea of glenohumeral movement with palm down. Again, just to let you guys know. And posterior shoulder often is a result of radial nerve irritation, so I'll do a lot of radial nerve glides, sleeper stretch kind of stuff. Rotator cuff strengthening definitely has its place, but maybe it's overutilized if we're not doing more global strengthening of the glenohumeral joint and the shoulder girdle. I do a lot of weight bearing. I speak in a couple of the posts about how important I think weight bearing is. So I do a lot of side planks, a lot of prone planks, things like push-ups, whether it be in the tabletop, kneeling, renegade rows, anything that you can get weight bearing. Just like the lower extremity, weight bearing is a big deal. And so certainly I'll look at the rotator cuff, but oftentimes I'll see significant differences in side plank in strength, and I want to exploit that and then change it and give them patients challenges to go do that. Some of the conversations, power of treatment-based classification, everybody was kind of in agreement that there should be perhaps a different way that we approach this, and I liked that. There's going to be more on this, so stay tuned. I think that this is one of the reasons that while you're reading the literature now or being brought up to speed on some of the literature, you got to continue to be in tune with what's being put out there, because there's more on this, and it's not going to happen all at once. I'm a firm believer that Paula Ludwig, the professor here at the University of Minnesota that I interact with on a regular basis, I think she's going to put something out. Other people are going to put things out, and they're going to eventually kind of have to come together to form something. But please stay tuned, because I think there's more. Everybody agreed that special tests have their place, but there's more to the complete examination. Use special tests. You might use a staging of criteria of irritability, as well as what the subjective information is, both ruling in versus ruling out. Everybody talked, or not everybody, a lot of people talked. A lot of people spoke very generally about how that they use manual therapy, and so it was a little bit hard to gauge what you all were doing. So I would ask, moving forward, to be a little bit more specific about what you're doing in the clinic. I think that that's really appropriate, and it gives us a better ability to exchange ideas and perhaps things that you use that might be helpful for others. Scapular mobility and strength. So again, I go back to weight bearing being huge. Nobody really seemed, at least in the ones that I've read in my Alpha and Bravo groups, and I did peek at Charlie and Delta, but I didn't see anybody, talking about, really being very particular about scap. I don't think you should. There's nothing in the research that says you should, but it doesn't mean you don't strengthen, right? And strengthen the muscles around the area. So I did appreciate that. And okay, so moving to week 3. So great information on lateral elbow pain or lateral epicondyalgia in both article and video format that's going to be coming. Your CAP project's going to be due Friday. Oh, that's not the 27th though. My fault. I got that date wrong. It's due on Friday. Make sure you close out your post Saturday at noon. Please. We had a few people kind of wait until the end. And I know sometimes things get busy and stuff, but if you're peeking in on Thursday and Friday and you're keeping up, that's really helpful. I was really pleased with some of the discussions that I was able to get into. We were really able to have 3 or 4 exchanges, and I think that's not going to happen every week, and I get that. But when you don't post until Saturday late or reply, it really shortens your ability to interact and then get that kind of deeper conversation. So hence, don't wait until Saturday morning to engage. So I hope you guys are all doing well. If there are any questions, you know where to find me. but so far things seem to be going pretty smoothly. We'll be engaging the fellows in their stuff, so if you want to peek in, now that they're posted their videos, if you want to peek in, I would encourage you to do that and kind of see what kind of dialogue takes place. Otherwise, can hardly wait to talk elbows, because again, a lot of good stuff and perhaps get people to think a little bit differently. Take good care. Enjoy the rest of your weekend. Hope you're all having a good one. Bye-bye.